So today's conversation is with Frank Yeomans. Frank is a psychiatrist and a psychodynamic theorist, practitioner. He's written many papers and books. I'll link some of them. Essentially, this conversation centers mainly around borderline personality disorder and sort of defining it from a psychodynamic perspective, specifically an object relations perspective, as outlined initially by Otto Kernberg, which I'll link a couple of his papers as well, which I found useful. And actually, so yeah, Frank describes what are the processes which define the borderline personality from an object relations perspective. So, for example, splitting and projection, and how actually also that these processes are not necessarily isolated to the individual with such a diagnosis. However, it's perhaps more prominent and becomes more pathological in these individuals. But actually, we see these dynamics such as splitting, in politics and groups. So yeah, it's a really interesting conversation. And yeah, Frank describes from his experience as a therapist delivering transference-focused psychotherapy, the sort of the ways in which borderline personality manifests. But I think really importantly, Frank describes actually how it's not a sort of a, what would you say, a prison sentence, that actually, from Frank's perspective, one can be cured in a sense of this diagnosis. Not always, but it is possible. Oh, and we also talk about mentalization-based theory and how that sort of differs from transference focused psychotherapy, both being psychodynamically oriented, yet they differ perhaps with regards to the drives, the Freudian drives. So actually, perhaps there is Frank acknowledges that there's greater appreciation for the fact that people bring their own aggression to life, whereas mentalization-based theorists are perhaps less concerned with such drives, but rather actually how people's earlier experiences led them to uh, lack a structure, a psychological structure to process thoughts, to represent thoughts, to bind thoughts and affects in the sense that Bion sort of did with regards to facilitating an environment in which thoughts can be thought, in a sense. Anyway, it's a great conversation. If you enjoyed it, yeah, and you enjoyed these conversations, feel free to subscribe because apparently it helps. But beyond that, or more importantly, yeah, I just hope you enjoy the conversation because I did. All right, thank you.
So, well, you're well known now for your work within or the umbrella sort of modality of psychodynamic theory, specifically around transference-focused psychotherapy. What initially drew you though to psychodynamic theory? Was it it felt right, or was it just circumstance? How did that come about?
More, it felt right. I actually got exposed to psychodynamic psychoanalytic theory when I was a graduate student in literature, thinking I would go off and make a career, teaching literature and writing about novels in particular or plays, less poetry. Anyway, uh, I had the misfortune, or perhaps the good fortune, to be studying literature at the graduate level when the deconstructionist movement was very much in vogue, which I didn't appreciate at all. I don't want to go into it, but it's a literary movement that does. I went into literature because I'm interested in people and society, and the deconstructionist school was much more abstract than that. So the long story short of it is that as a student of literature, I began to read some Freud, found it fascinating. I was always interested in how minds work, my mind, the minds of others. And it just was clear to me that if this area was interesting, it would be far better to go into the field of mental health rather than just apply psychoanalytic thinking through the the inert things that books are. You're not going to change a book, but you can help somebody improve their life. And I was especially fascinated by the idea of the unconscious. I mean, I don't think it's an exaggeration to say it's one of the great revolutions in thinking over the years in Western civilization. Freud's idea that there are things in us of which we're not aware that have a huge impact on how we feel, what we think, and what we do. And I think most people still are uncomfortable accepting that. And I think that's why a psychoanalytic approach is as widespread as psychoanalytic ideas have become. It's never well, it's certainly not now the mainstream of thinking in the field of mental health. I think it's a little disturbing to a lot of people. But in any case, So I had to do the long path of shifting from graduate school in literature to medical school and then a residency in psychiatry. I didn't know anything about personality disorders. Freud didn't really use that term, and one could see personality disorders in some of the cases he cited. But when I was in my psychiatric residency at the Weill Cornell Medical Center here in New York, in an odd way, the way I still am curious about, I seem to have some kind of affinity for the people who came in with personality disorders. At that time, the one that was spoken about most and still is borderline personality disorder. And it was interesting because most of my colleagues in the residency training had a kind of aversion to these patients because within the field of mental health, there's a terrible stigma associated to personality disorder, totally unfair and something I try to dispel. But, they are patients who are challenging. Sometimes they're called difficult patients. I think challenging is a better word because there's an intensity of affect, an intensity of emotional experience that is apparently difficult for a lot of people to deal with. But for me, that was the attraction. I thought that intensity was important to try to understand and appreciate. In addition to that, there was the simple fact that you couldn't just give these patients a medication and think you treated them. I was studying psychiatry at that turning point when the field was shifting from a more psychodynamic and psychoanalytic approach to patients to a more psychopharmacological approach. And, psychopharmacology helps a lot of people, but I'm quite critical of American psychiatry that now focuses on the symptom rather than the person. And when you're talking about personality disorders, you still have to focus on the person because the whole person is involved, not just their anxiety, not just their depression, treated as almost an infection might be treated. They're suffering from the symptom. Let's eradicate the symptom. I think it's much better for people to say, if you're having a depression or anxiety, what is there in your deep-seated way of thinking and feeling that would lead to that? And can we do anything to work at that deep level?
Yes. Yeah, and that makes a lot of sense. And when I hear that, and actually when I similarly encountered psychodynamic formulations of generally, but then specifically with regards to things like borderline personality, actually how it's very sort of validating, and I think actually in a way is quite compassionate because it both to the patient, but I think in a way it can be for professionals because it normalizes and sort of, how would you say, gives an understanding as to why you mentioned often professionals there's an aversion and a sort of like, well, there's no hope, where but through the work of Kernberg and colleagues including yourself over the, I don't know how long it's been now, a couple of decades, few decades, have, I think, elucidated, and I know it's not the only transference-focused psychotherapy. It's not the only, there's mentalization-based psychotherapy. I can't think of off the top of my head of others, but
Oh,
actually helping.
dialectical behavioral,
Right,
DBT.
yes,
Yeah, yeah.
yeah, of course. Although I
Oh,
suppose
you're thinking about the psycho.
yeah, I'm thinking psychodynamically only because of, and maybe this is where I'll ask you to now explain, if possible, the processes which are often characteristic of somebody with borderline personality and how that manifests, um, maybe not just only in the therapeutic space, but actually in their lives more broadly, and how there's a sort of that's actually why things like transference-focused psychotherapy works, because of this idea of, yeah, sort of transference, really. Yeah, does that
Yeah,
make sense? Yeah.
yeah, perfect sense. As a matter of fact, I'm very glad you sort of brought that perspective into our discussion because transference and the, let's say, dynamics of borderline personality disorder are not limited to patients. Every human being experiences the phenomenon of transference. And I think most of us, perhaps all of us, are able, I don't know if able is the right word, but have the experience sometimes of functioning mentally, emotionally, at what we refer to as the borderline level, which I'll get into later, based on splitting, which is a term that might be helpful to define. It's used all the time. I'm not sure it's understood all the time. But in any case, I'd like to start to answer that broad question of yours by referring to the title of one of Otto Kernberg's first works. It was called Internal World and External Reality. And I think that's a notion that we should all keep in mind. Our minds are made up of images that we take in through early development that set down memory traces. The images we have in our mind are not exact reproductions of what actually happened, because those mental images, those memory traces, are modified by emotions, by powerful forces in our minds, by wishes and desires, and by fears and anxieties. So the mental images we have are laid down, are not fully conscious to us, but are very important in determining how we perceive what's happening around us at any given moment in time. One of my mentors said the simplest definition of mental health is the ability to accurately perceive what's happening in any given moment around you and to adapt to the situation. So we have, all of us, I believe, the challenge of figuring out the degree to which the part of our immediate moment, for instance, my meeting with you this morning, I haven't met you before. Aspects of you, the way you talk, the accent, I have other British friends and so on and so forth, your look, that evokes in me the activation of certain internal images. Oh, I think I know what this guy is like, because unconsciously what I'm perceiving of you activates those things that exist already in me that I then we call project onto you or transfer onto you. That's the transference. It's the transference of internal images to external reality. But the challenge is to not stay with that projection, that transference, but to get to know you as the individual, the unique individual you are, and not just sit with my preconceived notions of who you are. So what we find is that in patients with personality pathology, I'm going to talk generally, not just about borderline personality disorder, the power of those internal images is especially strong, and for reasons that we can get into later, the impact of the external reality to modify the individual's perception doesn't function as well as it might. And I'm going to give what for me was the clinical example that convinced me of this method. My first patient in private practice after I finished my training as a psychiatrist was a kind of angry man in his 30s with a combination of borderline and narcissistic pathology. And in most sessions, he would be kind of difficult, let's say, always critical, devaluing of me. And the sessions were not easy, but that's what you have to sign on to and help the person with. In any case, after a couple of months in one session, he told me a story about something that happened to him as a child that was very moving and sad, and it brought tears to my eyes, which of course was involuntary, since as a therapist, I would prefer to look a little more neutral. But in any case, he said, "You have tears in your eyes?" I said, "Yes," since I didn't know what else to say. And he scrutinized me and looked at me very carefully and said, in all seriousness, he said, "You're mocking me." So I said to myself, that's what Dr. Kernberg's been teaching me about, the prevalence of the internal representation over external reality. If this man could see what most people would take as quite convincing evidence of sympathy or empathy, and because of the power of that internal image of the mocking, critical, devaluing person, he imposed that on me and didn't question it. So that's what transference is. And if we are more fully developed psychologically, we start in our experience of somebody by transferring certain images, but then we correct, we sort of refine, we get to know the person for the outside real person they are. But if you have the kind of pathology we're talking about, you're stuck, I say, relating not to the real person you're interacting with, but you're relating to your internal image that you're sort of pasting onto that person. And one metaphor I like to use is that the people we try to help are kind of prisoners of a system where they really relate to the images in their mind. And that's a barrier to getting to know the richness and potential of the outside real world.
Yes. Yeah, interesting. And what you're describing there, maybe for those who are not so familiar with the literature and stuff, but what you've just described there, I believe, is often coined an object, is it an object dyad, an object relational dyad,
Yeah.
which is typified by anytime one interacts with another, there is a representation of the self, representation of the other, and there's an affective component. And in with individuals that present as they have borderline pathology, they're often very, how would you say, intense and quite sort of stark, those
Yes.
dyads. Yeah, would you be able to talk on that?
Well, yes, because you're kind of bringing us to the topic of splitting that I mentioned and that we should elaborate a little bit more. Any psychodynamic or psychoanalytic approach is based on the idea that there's conflict within the mind. And I'm simplifying a great deal, but when we're dealing with personality pathology, we're dealing with people who haven't made a lot of progress resolving a fundamental conflict between aggressive feelings within the self and loving feelings within the self. Um, as I say, I'm simplifying, but for the sake of argument, as the individual is developing right from birth through infancy and being a toddler, they experience moments with others that are either very pleasurable when their needs are being met and they're being satisfied and love nurtured in a lovely way. But in the life of every individual, every baby and then toddler, there are moments of pain and dissatisfaction. The caretaker, it doesn't have to be outright trauma, but the child is in pain, is hungry, is soiled, is wet or cold. The caretaker isn't immediately available. The child doesn't have a sense of what we call object constancy, which is, oh, I know mom is around somewhere and she'll come as I don't have to worry so much. They live only in the moment. So when their pain is not being immediately relieved, they go from heaven, where the caretaker is taking perfect care of them, to hell, where they're suffering, and they associate their suffering with a persecutor. I'm suffering and somebody else is responsible for it. So early on in life, those dyads that you just referred to, the experience of self in relation to other, sort out into two radically opposed camps. The perfectly cared for self in relation to the perfect other, perfect caretaker, and the suffering self in relation to the persecuting other. So what happens over time in more healthy psychological development is that the two extremes begin to blend together and we get what we call an integrated sense of self. Before I get to the sense of self, I have to talk about what we call the paranoid schizoid position. I've already described it. Your mind has one side where everything is lovely and the other side where everything is terrible. Melanie Klein, the great analyst following the footsteps of Freud, called that the paranoid schizoid mental organization. Schizoid because it is split, all bad or all good. But why is it paranoid? Because the individual whose mind is made up that way doesn't own or take responsibility or have full awareness of their aggressive feelings. For various reasons, they're not comfortable with those aggressive feelings. So they project those and see those as coming from the outside. So their general stance to the world is one of lack of trust, of mistrust, of fear and anxiety. So if a person develops more successfully in terms of their psychology and mental states, as I said, they begin to blend the two. That involves two things. One is giving up the ideal. Because in that split frame of mind, the good is not just good, it's perfect. You have the perfect caretaker and you can be perfectly taken care of and be perfect yourself. That doesn't exist in reality. So as you mature psychologically, you have to mourn this idea, I can find the perfect caretaker, I can find the perfect partner, I can be the perfect self. So there's a sadness in that awareness, but you're going to be better you're going to be able to adapt better to reality. In addition to mourning that sense of ideal in self or other, you can have ideal in principles, spirituality, art, ethics, what have you, but not in people. Um, as you mature psychologically, that aggression that you used to project and felt was always coming from others, you say, oh, hey, I can be aggressive. That's part of me. And you feel a guilt and remorse. But what you end up with is a sense of self that has the full range of emotions. I can love, I can hate, I can feel everything in between. That's when you can deal with the world more realistically. But our patients and a lot of people who unfortunately aren't seeking treatment function in that split way. Things are all good or all bad. I don't know if I've answered your question. I
You
spoke.
have.
Okay, yeah.
You've answered it in a way which you've elaborated it better than, yeah, and you've sort of, yeah, contextualized it more wider than I was hoping, actually. So yeah, that's great. Yeah. And so then yeah, and what actually that really affirms, and in a way which I hadn't quite appreciated, was the influence that Klein has had on Kernberg and his colleagues, such as yourself, in this sort of transference focused psychotherapy with regards to the splitting. And actually, yeah, so then I guess when we're talking about somebody who would meet the diagnostic criteria, or we would describe as having a borderline pathology with reference to the way their object relations manifest, it's predominantly one which is typified by splitting. And
Mhm.
as and because of the splitting, how do the defenses, I suppose, of like projective identification and stuff relate to that splitting?
I'll get into that, but let me elaborate a little bit more before getting to the defenses,
Okay.
because I wanted to give an example of a patient who, in her own words, described what I was describing more theoretically. She was a lady who had a relatively severe case of borderline personality disorder. She engaged in a lot of self-harm, but she could also be very uh, aggressive with her husband, sometimes getting into physical fights with him and hitting him, and to the point sometimes he had to call the local police to come and, get the fight ended. So after about 2 years of therapy, she came into a session and said, you know, oh, let me preface this by saying our whole goal in transference-focused psychotherapy is to help somebody go through that path where they shift from the paranoid schizoid split position to the integrated position, the more complex and whole position. But
Yes.
the path that's very painful. It's
Mm.
painful because people don't want to give up the ideal, and it's painful because people don't want to feel their aggression. So to get back to my patient, she came into a session and said, you've helped me a lot. Um, I can get along with my husband much better now. We can enjoy our time together. We're like friends who can, you know, um, enjoy each other's company. But she said, you've taken something away from me, and I kind of resent that. She said, I used to truly believe I would find the perfect man, the knight in shining armor, the man who would solve all my problems and make life just ideal. And now I've realized that's not possible. That's a patient's description of mourning the ideal object. Then the next session, she came in and said, it was hard for me to come today. I feel so guilty. I feel guilty about the things I used to do to my husband and sometimes to you. And when I did them, I thought I was totally justified. Now, she's talking about the fight she had with her husband. Sometimes in sessions with me, she'd like yell at me once she threw my briefcase across the room. It wasn't anything terrible, but it was a little, aggressive. So she said, when I did those things, I thought I was totally justified. My husband or you upset me. And when I was upset, I just reacted. Now I see there was aggression in what I did, and that makes me feel terrible and guilty. So then you have to work with somebody to, in what we say, kind of better integrate all this broader range of feelings that they're now owning rather than projecting. And that gets to the defense you just mentioned of projective identification, which is still controversial in the field of mental health. Some people think it's kind of hocus pocus because the whole idea is that if a person is not comfortable and literally cannot consciously accept an emotional state within themselves, they not only see that emotional state in others, that's simple projection, but sometimes they actually, through indirect ways, get the other to feel what they can't feel in themselves. And as a therapist, that gives you a lot of information you can work with. It's very powerful to see how patients can't accept certain parts of them. It's also understandable. But to give you an example of projective identification, there's a patient of mine who most of the time behaved very well. He was almost like, we use the term a Boy Scout. He was very proper and nice and kind and helpful, as I said. But periodically, another part of him would break through, a very violent part, and he would make not just suicide attempts. I mean, I don't want to minimize any kind of suicide attempt, but more violent than average, the way he cut himself, very deep, very jagged, making terrible scars and requiring sometimes a little surgical intervention. So what was split off in him that he couldn't feel as part of himself was aggression and hatred. But as I said, most of the time when that wasn't breaking through, he was helpful and cooperative. So in a session, he interacted in me. Sorry, he interacted. It's funny, I said in me. He did work on something in me. He interacted with me. He was a very bright guy, and he had a particular way of being devaluing and critical and sort of humiliating, if you will. And I'm listening to him as we do in sessions. I'm trying to pay attention. And in the back of my mind emerged, as though we're emerging out of a mist, the image of strangling him. And I said to myself, well, that's kind of interesting. I mean, we all have our own unconscious therapists as well as patients. And I'm listening to him, but noticing this image emerging in my mind. I said, I don't think I've ever imagined strangling a patient before. I said, I think he is creating that in me. The way he's treating me, he's exporting to me the feeling he can't deal with in himself. So at that point, for lack of anything more articulate, I simply said, I think at some point it would be important to think about hatred in the mix of everything else we talk about. And that was naming what he had in him that he couldn't accept in him, and that through this defense mechanism, he managed to kind of free himself of, at least temporarily, and make it seem like that was in the other.
Yeah, it's really interesting, that story, and it's really interesting. That anecdote you mentioned, the reticence or the not disdain, but the aversion people have to projective identification, and it makes me wonder as well if it comes back to what you spoke about earlier. Also, how actually there's, for many people, maybe even at times people within mental health, there's an aversion to the idea of the unconscious. And it is interesting. Is it, a function of the kind of the type of society we live in, which is very sort of individualistic, and we're sort of within the kind of capitalist framework, it's very egoic and dependent on the egoic faculties. And actually, yeah, it's just interesting because I don't know. My sense is that when one's worked I mean, well, I said this to a supervisor once actually. I don't think you even need to be. It doesn't even have. You can. I've identified. I believe a projective identification. Just in day-to-day life, day-to-day life. But anyway, that's. I don't. How much reticence is there? I mean, even within psychodynamic theorists, or do you find that generally psychodynamic theorists are always amenable to the idea of projective identification, or is even there at times a sort of a question mark with it amongst such people?
I don't want to get into all the details about the different schools and divisions within the
Mhm.
psychoanalytic community. The short answer to your question is yes, I think there is not full acceptance of that concept. But could I go back to your comment about society and the nature of our kind of pragmatic, materialist societies? Because
Mhm.
when we developed transference-focused psychotherapy, we began to teach it in many countries throughout the world. And
All
at
right.
this point, we have more than 24 chapters in different countries. And our experience is that our approach and psychoanalytic approaches in general tend to flourish more in more Latin countries than in Anglo-Saxon countries. And we think it has to do with the pragmatism of the Anglo-Saxon world. I'm simplifying greatly, of course,
Of course.
and a certain tendency to be a little more theoretical and philosophically minded in the Latin world. So I do think there are societal implications. I find myself frustrated with North American pragmatism. Um, but if we're going to talk about society, let me add one comment. I don't know if this is within the boundaries of what you anticipated, but when I talked about splitting, we've got a world that's all good on one side and all bad on the other, with the projection of the badness onto the
Mhm.
outside world. Unfortunately, that configuration is not limited to individuals. Groups can think that way. And
Mhm.
that's what all fascism is about. When
Mm.
a leader says, you know what, we're good. There's no question about that. If we have problems, it's not because of anything in us, it's because of these outsiders. So we
Mhm.
have to get rid of the outsiders or eliminate the outsiders. And that sounds ridiculous, except it has a seductive appeal to huge numbers of people. And I am trying to communicate that this shift from splitting to what we call integration and complexity in one's sense of self, one's sense of others, and one's sense of the world is difficult. There's a kind of a siren's call to return to simplicity. Isn't it nice, a world where you know exactly what's good and exactly what's bad? So I think we're all subject to that seductive appeal of splitting, and it's a risk to society.
Yeah, definitely. That makes a lot of sense. And I think attests to when I hear that actually, whilst this we're talking of like the splitting is characteristic with people who are sort of borderline, that actually it's not limited to, and perhaps yes, it can manifest itself very clearly in the sort of the political space, but actually at the individual level, people who are maybe not necessarily uh, borderline. I don't know. Maybe if it's when affect as well becomes extreme.
Yes.
Um, yeah. So then, because it's a sort of, I guess it's a quicker heuristic or something to make sense out of stuff. But just coming back to the with say in your experience working with borderline patients and maybe what the theory and the research you've conducted and read over the years. So I suppose what you're saying is that the aim of the transference-focused psychotherapy is to help the person become more integrated, or I don't know if it'd be amiss to suggest, in the Kleinian sense, reach the depressive position,
Yes.
right? And then they can, but that's painful. That is painful. Though, so prior to that, though, is it possible, for somebody with a borderline pathology to having moved? So let's say they are I don't want to say possess, that's not quite the right, sort of inhabit the overwhelmed, let's say, by an object relational diet in which they are very punishing, is, you know, very aggressive, and
Mhm.
they do damage to another, let's say. If they are yet to really have become more integrated and, let's say, reach the depressive position, well, they're not perennially in that sort of object relation where they can actually sort of what's the word, invert that, whereby they then they're actually the opposite. They then feel like the victim and stuff. So I suppose what I'm trying to understand is, will a person ever feel that guilt if they've not yet reached the depressive position, where they're still in that space where they're just sort of, it's very sort of dissociated? Does that make sense? Like, as in, can they
Yeah.
look back upon the dissociated, punishing part of themselves and go, "Oh gosh, I was punishing there," or yeah, sorry, yeah, I'll leave it.
No, no, no. It's a very important point because there's a distinction to be made between the genuine acknowledgement of one's aggression and the appropriate guilt, which then have to be worked on. We don't want to leave people feeling bad about themselves. We want to help them find more acceptance. But there's a difference between that form of guilt and the terrible self-loathing and self-attack that many borderline patients experience. So that's not, oh, I feel bad for the aggression I manifested. That is turning the aggression that may be directed towards others, as in the case of my patient who would hit her and sort of beat on her husband. That same raw aggression can turn against the self, but that's not the depressive position. That's the ongoing, that's a variant of the split position, but with the target of the aggression shifting from other to self.
Yeah.
So when we get to the depressive position, we have a person who can be in the same moment aware of their aggression and guilt, but still kind of psychologically in contact with other feelings. So they are now open to the whole spectrum, the whole range, and their psychological life isn't dominated by just one emotion at any given point in time. We talk about contextualizing the emotion, so say you're with your partner and they do something that frustrates you, you say, damn it, they drive me crazy, but I still love them, as opposed to the borderline patient who would say, I can't stand this relation, I'm going to get out of this, they're just terrible. You contextualize it when you're able to add that, but I still love them and I think about all the good stuff. There was something in relation to that, but I can get back to that later if it occurs to me. But why don't you get back to whatever you were going to ask?
Yeah, sure. So
Oh, excuse me. I remembered what I was going to say.
of course, yeah, go ahead.
We talk about this progression from the paranoid schizoid position with all that projection to the depressive position with awareness of one's aggression and integration. We talk about that as though that's a developmental pathway that takes place once and for all. But as you suggested in a comment about emotional intensity and stress, these are two psychological organizations that can shift back and forth.
Mm.
Even if we have achieved the integrated state, if we're under enough physical stress, if we're sleep deprived, if we're under enough emotional stress, we can regress to splitting. And we have to watch out for that in all of our mental functioning. But that's what I find fascinating about a psychodynamic approach. Psychodynamic means the mind in motion, and all of our minds are in motion, and we have to be watching out all the time for where they're going and what they're doing.
Yeah, yeah. Yeah, exactly. Always in motion, and that's the sort of the premise of psychodynamic therapy, really, to help the mind move and perhaps towards spaces which are more adaptive and healthy for the person. Which makes me think of, well, there's 2 points. Okay, so I've mentioned mentalization-based theory, and I'm curious to what extent have you maybe I don't know if you can speak to just yourself or you and your colleagues who have been working in the more sort of transference focused psychotherapy, perhaps not borrowed, but perhaps how has it shaped your understanding, or maybe just helped you give a new reading to actually at times what's going on in the transference focused psychotherapy? So, for example, I know there have been studies done which have compared transference-focused psychotherapy, DBT, and possibly mentalization-based therapy as well. And interestingly, transference-focused psychotherapy improves reflective functioning, whereas something like DBT doesn't, or at least doesn't to the same extent. And so then, does that, yeah. So then, yeah, does that make sense?
Yeah. First of all, I'm not aware of a study of DBT in relation to mentalization-based therapy. That would be a lovely thing to have. These studies are very complex and unfortunately very expensive. So in an ideal world, I would create a study like that, but we don't have a exact comparison in terms of research between TFP and MBT. But we've done a lot of thinking. Unless there's something you're aware of that I'm
I'm
not.
sure I read a study where they compared the reflective functioning in DBT versus TF.
That we did, reflective functioning in DBT versus TFP.
Yeah,
But
sorry, that's what I was referring to. Yeah.
yeah, there wasn't an MBT cell in that study,
Okay, yeah,
unfortunately.
yeah, yeah,
But
yeah.
we did that study before MBT kind of came on the scene.
Okay,
But
interesting.
DBT and TFP were around, and then MBT came. And MBT is a very, very good therapy that helps lots of people, as you, I'm sure, know. It developed through the National Health Service in the United Kingdom, and their
Mm,
whole goal was to provide a somewhat simpler version of therapy that could be learned relatively quickly and carried out by nurses within the NHS. Of course, it's grown from there. But especially in the initial stages, there was a lot of dialogue between Kernberg, the other members of our group, and me, and Fonagy and Bateman, and Mary Target, and that group there.
mm,
Very interesting exchanges. So I think there's a lot of overlap, especially in what we call the first stage of TFP, which is the clarification to the degree that one can of the contents of the mind, because mentalization is, establishing a better awareness of the contents of one's own mind and the contents of the other's mind. But what we see as the main difference is that after that better understanding of the contents of the mind, we focus more on that deep intrapsychic conflict I've talked about, the basic conflict between loving feelings and aggressive feelings. And we don't see MBT going into that level
mm,
of trying to resolve the deep unconscious conflict. And this leads to perhaps the relevance of talking a little bit about how different models conceptualize trauma with regard to borderline personality disorder, because DBT, MBT, and schema therapy put more of an emphasis on trauma as the causal effect and as a big part of what needs to be resolved. And we in the TFP world acknowledge for sure that a lot of patients with BPD have experienced trauma. If you look at the BPD population, studies have shown about 2/3 have had trauma in their personal history. So clearly there's a relevance to thinking about trauma. But I think it's a little naive to say trauma leads to BPD, pure and simple, because there are studies that show if you take a bunch of people in the general population, not the clinical population, but just people out there who aren't in treatment for anything, and you interview them and you establish the subset who have experienced trauma. So you've got this group of people in the general population who have experienced trauma. The majority of them don't have any kind of psychopathology. So it's a little bit more complicated than trauma leads to pathology. I think it has to do with the way the trauma is processed. And I don't want to minimize the role of trauma, but I don't want to put all of the blame on trauma, because one of our main theoretical differences with the MBT folks, although this is from readings I did some years ago, so there may be some changes in their position, I don't know,
Yeah.
is what's called in the MBT literature the alien self.
Yes.
Traumatizing caretaker that, to use their word, colonizes the mind of the patient, and the patient confuses that image of the traumatizing other with the self. And mentalization helps the patient sort of detach from their internal alien object and sort of re-export the alien self to the external world where it originated and belongs. So in that sense, it's a model that sees aggression as pretty much exclusively, although they probably would not accept that word. It'd be an interesting debate to have in any case. But the aggression in the MBT model is associated more with the traumatizing other than as an innate part of every human being. That's one thing that frustrates me about the current world. I think society and a lot of individuals deny the fact that we all have aggression. The humans
Mm.
had to have aggression to survive. And aggression isn't all bad. It can be mastered, it can be channeled into creativity and competitiveness and ambition. But there's a kind of simplistic notion that aggression comes from the outside, and that is behind the forms of treatment that I say are more trauma models. Our view in TFP is that everyone in their own mind is going through life with a kind of a tug of war between being aggressive and being loving. And, one of the challenges of life is blending those two in a successful way. But what about the borderline individual who has experienced trauma? It's hard for them to accept their own aggressive feelings because they have internalized an image of a terribly traumatizing other. And as soon as they feel a little aggression, they think that makes me a horrible person and
Yeah.
maybe I'll kill myself. One of my patients in a session, lovely young woman, except when she was engaging in her unfortunate suicide attempt, she did better in the end. But in a session, she banged her fist on the chair and said, "I'd rather be dead than think I have anything in common with that horrible father of mine." And I said, "You just described your problem beautifully. You'd rather be dead than think you have anything in common. I think it's almost inevitable you have something in common because we all have some aggressive feelings. That's human nature. But if you feel the least inkling, the smallest inkling of aggression, that connects automatically to this image of a horrible abuser, and you can't tolerate that. So let's slow down and unpack that."
Yeah, it makes a lot of sense, and I suppose it just emphasizes the kind of like the drive in the Freudian sense component that underpins a lot of the transference focused stuff. And maybe lastly, just on you mentioned in the name psychodynamic is the idea of change, and then when we come to the borderline pathology, how do you and your colleagues say how not just define the phenotype, but the idea of change insofar as does someone ever get to a point where you then, when you're talking amongst it, or you're at a point of discharge, is it theoretically possible to go, well, this person is no longer borderline? Does that make sense?
Absolutely. And the answer is there is that possibility. It doesn't happen in every case. I would divide the trajectory of patients roughly, this is simplifying, of course, into three categories. There are those who don't change. That's a minority, but that can happen. Then there are those who change symptomatically. They tone down their emotional intensity. They have better affect regulation, fewer outbursts. They stop acting out. They stop the self-destructive and sometimes aggressive towards others behaviors. So you can get that symptomatic change, but not always with the deeper internal change that is our desired outcome in the best of cases. So that's the third category, where somebody not only changes symptomatically, but they really have developed a different subjective sense of self. They have that sense of a fullness of self, a full range of emotional experience. So in the latter two groups, those who do change, a lot of people no longer have borderline personality disorder. In fact, toward the end of therapies, the patient sometimes says, am I still borderline? And you think together and you realize, well, no. Um, that doesn't mean the person is free of problems in their life, but
Mhm.
they're in a much better position to deal with them. But we're still trying to figure out what, how to understand the difference between the group that changes uh, in terms of improved symptoms, but they don't seem to have achieved that full psychological integration. How to understand the difference between that group and the group that has. I think it's always good to root this in a clinical example. One of my patients who did very well, she went from being suicidal and rather seriously so to now working successfully, being married and having a child and being a good mother. She described her current experience in the following terms. She said, I'll be in a situation and I'll still have that gut level reaction that used to flood me and overwhelm me and control me. I'll still have that gut level reaction. But as soon as I have it, I think about it and I work on it and I don't act on it and I sort of deal with the situation more successfully. And I think I'm very pleased at the way she's finding satisfaction in life now. But maybe I'm too demanding, but in the best of all worlds, it would be nice if she could say, in a situation, I don't have that gut level reaction anymore. We're saying I have that gut level reaction suggests that very deep down, maybe she still has some vestige of splitting, but she
Mm.
can get a handle on it more quickly. To go the full 9 yards, that expression might not mean too much in the UK, but to go all the way would be to say, I don't have those same gut reactions.
Yes. I have other questions, however, I'm mindful of the time. So I wonder if we wrap up for today.
Well, I'm torn because it's a fascinating discussion. If you could tell me the questions and we could deal with them in like 5 or 10 minutes, we could go on a bit, but
All right.
whatever.
Yeah, so it was really so I think we've clarified the distinction between MBT and TFP. And it's generally around, I think, the transference-based approach sort of acknowledges how the individual has to assume some level of responsibility, perhaps for, or maybe more in the sense of how they are contributing to perhaps some of their distress, for
Yeah.
for example, through aggression and things. To what extent, though, is there a acknowledgement of pernicious social environments? And I say this as well because I was doing some reading on one of the books you authored or co-authored, and it was sort of a manual or enumerating the process, the procedure of delivering transference-based psychotherapy. And one of them was at times where I don't know if it said appropriate, but at times actually having conversations with the family members and sort of
Yeah.
explaining to them. When I was reading that, I was thinking, given and which MBT places a particular focus on, what about in those instances where, yes, fine, we can acknowledge the aggression and things like that. However, we can't get away from the fact, though, that maybe the environment they're embedded in itself is aggressive, or there are members within that environment who themselves engage in splitting and things. Is that something a transference-based psychotherapist would have to just sort of try and track and be aware of?
Absolutely. I'm smiling because everything we've discussed so far is a kind of a uh, slimmed down, reduced uh, example of how the therapy might get carried out. I've given guidelines and
Mm,
concepts that sort of define us. But in each individual case, you have circumstances that need to be taken into account, such as the real family context and even the social context. I don't want to get into that right now, but with regard to the family, one of the ways we deviate from most traditional psychoanalytic practice, and we're not psychoanalysts in its pure form by any stretch of the imagination, but we do apply psychoanalytic concepts and techniques to the patients we see. But increasingly, at the beginning of therapy, as we're getting to know the patient, because we have to get to know them, then we have to discuss our clinical impressions of them with them. We tell them how we understand their difficulties. Then we set down the plan for treatment and see if they agree. Part of that process increasingly is to have a meeting with the family. That's for various purposes. One is because in the context of American psychiatry, most families think, oh, my partner, my daughter, whoever it is, my son, has a symptom. So, the therapist should just treat the symptom. We have to educate the patient and also the families as to what a personality disorder is. It's nothing to be ashamed of. It's difficulties in the way one experiences oneself and others. So we have that family meeting both to educate the family so they will understand better the treatment approach we're recommending and to get a sense of the family. Maybe we see all kinds of family pathology. Now, we just have to take that into account and factor that into our appreciation of the case. We're not going to, meet the next time with the patient and say, oh, yeah, I see where your problem comes from. They're all crazy, because that would be too simplistic. But we kind of gauge what's going on in the family and factor it into our understanding of the patient and the context from which they come.
Yeah, makes sense. Yeah, really very interesting. Yeah, I think you've answered my question.
Okay, it's been a great discussion. I hope it served the purpose.
Yeah, it's been great.
So
Yeah.
I can tell we share our interest in this topic and I hope the listeners, by the way, I just end by saying personality disorders is not what we call here a household word. People don't sit around the dinner table and say, hey, let's talk about personality disorders and try to understand them better. But it's a fascinating topic, and it would be helpful if more people in the world knew about them, understood them in a way beyond the stigma that's associated with them, and gain an interest in understanding them and thinking about them. So I hope that's one thing that'll come out of this podcast.
Yeah, me too. I think that's yeah, definitely. Okay, great.
Thank you.